Okay, I know everyone is engaged in their meal. We're ready for our noontime speaker today, Dr. Edward O'Neill. We're very excited to have with us. He earned his medical degree from George Washington University, completed his residency in internal medicine at Boston Medical Center. He completed a 3-year Kellogg National Leadership Program, and in 1998, he founded a nonprofit organization called OmniMed. OmniMed has run programs in Belize, Guyana, and Kenya. This organization is partnered with the Ugandan Ministry of Health and the U.S. Peace Corps, and has developed some innovative health service programs in Uganda, including training of 1,000 community health workers and developing measuring parameters for program efficiency. He's also written 2 books that were published by the American Medical Association. One is called Awakening Hippocrates, and the other is A Practical Guide to Global Health Service. So he'll be talking on these subjects today. He's also the chair of the Brookings Institute Task Force of Health Service at Sub-Saharan Africa, and he's currently an emergency room physician in Boston, and also an associate professor in emergency medicine at Tufts University Medical Center. So please join me in welcoming Dr. O'Neill.
Thank you. Thanks, Mark. Thank you, Dr. Johnson. Can you all hear me okay? Okay, we're good with sound. So first, I just want to thank Dr. Gonzales as well, President, and Dr. Johnson, the rest of the board for inviting me here today. I'm honored to be with you at such a prestigious group. And also Teresa Busquedra and the staff have done a wonderful job. I feel very warmly cared for here, and it's great in our last meeting just before here to see so many people interested in this realm. Now, I'm going to be talking today about global health inequality. And for me, this all began when I was a 4th-year medical student at George Washington University. I went to Tanzania, I saw the animals, I climbed Mount Kilimanjaro while there was still snow on it, and then I really worked with some people that reminded me a lot of the people I grew up with in Boston. Good, hardworking people that seemed to deserve better. People that really defied the impoverished circumstance with a grace and a dignity that was inspirational to me. And the longer I spent in Tanzania, the more it became clear to me that their problems are our problems. And I want to talk to you today about each of us getting involved in this. And what I really want to do is focus on 2 fundamental questions in the realm of global health inequality. And the first one is why? The first question has to be why? In a world abounding in the knowledge, the talent, the technology to change these incredible disparities forever, why do these things persist? Why? We'll look at it from a why we should act as well as what the history has been, and then we're going to focus a little bit more on what we can do about it. Talk about some icons in the field, and then we'll go on from there. But I'd like to start out with a story. And I think it's always good to set the tempo for something like this. And I want to start out with the story of this gentleman. About a century ago, in fact, almost exactly a century ago on Good Friday, a young man and his new wife set sail from the south of France. They sailed 5,000 miles hugging the west coast of Africa until they came to a place called Ndende in Gabon. There, in a converted chicken coop, they set up a clinic. And through the next 50 years, treated patients in what his daughter later described as a monk-like existence. Now, when they set sail, this was no ordinary man who set sail from France. At the time, he was widely known all over Europe. He was a theologian, a minister, he was a philosopher, he'd published widely, and he was a concert organist, playing the works of Johann Sebastian Bach. Everybody knew him. He was a rising star in Europe. A modern equivalent would be hard to even comprehend. Justin Bieber, maybe. Britney Spears. Our culture's declined maybe a little. But he was widely known and widely respected, and he made the decision that he would pursue the things that he loved, philosophy, theology, and music, until the age of 30. But then at the age of 30, he said he wanted to work with his hands instead of working with words. So he said he'd give all that up, all the loves that he had for those things, he'd give them up, go to medical school, and then go to Africa to work among some of the poorest people in the world. And that's what he did. Now, about this decision, his family and friends, they chided him. They said, "Why are you throwing away such promise? Why are you giving away 3 prosperous careers to do something that somebody else could do? Let someone else do those things. It doesn't have to be you." And about that extraordinary decision, this is what he had to say. He said, "It struck me as inconceivable that I should be allowed to lead such a happy life while I saw so many around me struggling with sorrow and suffering. The thought came to me that I must not accept this as a matter of course, but must give something in return. It seemed to me a matter of course that we should all take our share of the burden of pain that lies upon the world." Now, of course, this man is Albert Schweitzer. And Albert Schweitzer, in addition to winning the 1952 Nobel Peace Prize, became an icon in our profession. His long, silent voice speaks to us still, powerfully commanding us. Schweitzer talked about an ethical imperative that we all share to care for all people, not just those in our traditional realm of concern. In Schweitzer's powerful argument, Reverence for Life, he stated, "My life is my argument." John Kennedy called him the towering moral influence of the 20th century. And he, again, remains an inspiration to us still. Now, when Schweitzer set sail from Bordeaux, France, in 1913, he sailed a number of miles, but he crossed a number of other barriers. Across barriers of health, wealth, and longevity. And when we talk about this realm of how we engage the world, the impoverished world, the world of those who are less fortunate than we are, the first thing we have to do is describe, well, what are we talking about? Well, we're talking about global disparities, enormous disparities that define the haves and the have-nots. Now, things are getting a lot better, but there's still these enormous disparities. And if you look at this chart, this shows life expectancy. OECD is the Organization of Economic Cooperation and Development. SSA is Sub-Saharan Africa. Basically, the rich world club versus the poorest section. And the reality is that still today, life expectancy is 25 years different, about like turning the clock back almost a century. When I flew from Boston to Uganda in March, I flew back almost a century in time. And that's unfortunate. Now, if a 75-year-old dies, that doesn't affect the life indices tables much, but when a child dies, it affects it a lot. And the ultimate barometer of health is life expectancy. And that's really where the biggest difference is. If you look at this table, infant mortality in sub-Saharan Africa is 15 times higher, whereas under 5 mortality is 20 times higher. Or as Thomas Hobbes says, for the poor, life is nasty, brutish, and short. Now, our response to this we'll get into in a second. But I have to preface this slide by saying that the determinants of health, contrary to what our egos may tell us, is not really us as much as we think. What really determines health in developing countries is food, and clean water, and sanitation, and public health measures, and jobs and economic growth. But health workers are important, and that never became more clear than during the HIV crisis, right? When we looked to ship all these drugs out into the world, and we found that the clinics where they most needed to be dispensed weren't staffed. This is a seminal study from the WHO called Working Together for Health, published in 2006, where they looked at the number of health providers that were short. And worldwide, we're about 4.3 million health providers short, with 1.5 million short in sub-Saharan Africa alone. And that's a real tragedy. Now, if you look at this slide, this shows you the United States is an average of 1 physician for every 370 people. Sub-Saharan Africa is about 1 physician for every 5,000 people. A few years ago, when I gave talks like this number was about 3,000. Now it's 5,000. Why? Because Africa's population is exploding, and the number of physicians being trained is small. I put this in here just to make the point that the countries that have the least ability to deal with it are the same countries that are hit by the hardest health problems. 2/3, 69% of the world total of HIV-positive people, 34 million, live in sub-Saharan Africa, and they just don't have the infrastructure to combat it. And that's an issue. This slide makes that point a little more clear. In the global burden of disease, about a quarter of the global burden of disease is in Africa versus 10% in the Americas. The workforce, 3% versus 37% here. And the global health dollars, less than 1% is spent in Africa, where it's over 50% here. The point is this. You can summarize this slide by saying the following. It is far more likely that a U.S. citizen will receive an inappropriate antibiotic for a cold than someone living in sub-Saharan Africa will receive a potentially life-saving antiparasitic drug for malaria. That's the reality of our world, and it's tragic. Ours is a world in which 10,000 people in Africa die every single day of 3 illnesses for which we have treatments: HIV, TB, and malaria. Our world is one in which 500,000 women around the world die in childbirth in poor countries at rates 10 to 100 times those of the rich world. And perhaps most tragic at all, you've probably all seen this, about 22,000 kids under age 5 die every single day of treatable illness, about 1 in every 4 seconds. Now, these are some of the kids that live near us in Uganda. This is Gracie. These are her brothers and sisters, and these are happy, fun-loving kids. They remind me of my kids, although they're probably a little bit better behaved. These are wonderful kids. They sing, they dance, they laugh, they learn, but they die. And they die at rates that, while improving and while getting better, still remains unconscionable and something that we need to address. This map shows where the deaths occur. 8 million kids a year in 2009, again, half of them in sub-Saharan Africa. That's something that really needs to change. Now, this slide really looks at the reasons why. And I want to just say at the outset, this is not a political pitch. These are all on one side of the political spectrum. That is not by intent. In fact, if you break it down by parties, the Republican Party has actually done more to address these issues than the Democratic one has. But let me just say this. When we look at why things are as they are in our world, we have not always been great about addressing the problems, but we always have solutions. Paul Farmer has rightly called these claims immodest claims of causality. And it goes back to the Bible, right? In the 1830s, just to keep the theme, in the 1830s, U.S. ministers said that cholera was sent by God to punish sin. It's a rod in the hand of God, right? In other words, it's a biblical notion that people who get sick are sinners. And the other piece of this, too, is either Jesse Helms or other commentators saying that you send money to these places, it's like going down foreign rat holes. Or the other comment that Africa, it's a place in chaos, you really can't do anything there, money just gets wasted. Now, I'm not going to stand here and say, after having worked in Uganda for the last 6 years, that corruption isn't a problem. It's a huge problem, but it's not the problem. And this brings me to this point here, and I love this quote from Oliver Wendell Holmes, who was a Supreme Court justice about a century ago, and he said this: in our world, there are 2 types of simplicity. He said there's a simplicity on the near side of complexity. He said, I wouldn't give a fig for the simplicity on the near side of complexity, but I'd give my life for the simplicity on the far side of complexity. The simplicity on the far side of complexity. What did he mean by that? Essentially this, that there always has been and always will be simplistic, reductionist, and erroneous explanations for complex phenomena. They hate us for our freedom. They're sick because they're sinners. They're poor because they're lazy. But if we want to try and understand what's real in our world, we are required to take a far more arduous journey into realms that are not our traditional training and not our traditional areas of understanding. We're required to go deeper and debunk the mythology of poverty. Now, I wrote the book Awakening Hippocrates to really try and get people to think more broadly, to try and understand why things are as they are in our world. And what started out as a mere database of service opportunities by necessity became a deep exploration of these complex forces that conspire to rob the poor of their agency or of their very lives. And if you try and understand this, time does really not permit us to get through this. I understand I have 1 hour, but these are really the reasons why. That's what I go into in the bulk of my book, which is available here. But these other books are very important as well. And from the perspective of a young woman growing up in the Kibera slum, for example, in Nairobi, or any other poor setting, these forces are largely invisible and they're powerful. Let's take just a few examples. Governance. This is a book by Darren Acemoglu and James Robinson that addresses these issues clearly. And it takes the example of looking at the United States and Mexico, right next to each other. Why are they so radically different? An extractive government, like in many poor countries, that takes from its people is radically different than a country like the United States that facilitates innovation and economic growth and job opportunity and creativity. And that's one of the defining issues all around the world, critically important. Infectious disease, HIV/AIDS. This is a devastating epidemic. And as I already showed you, 69% of the 34 million people living with HIV in the world are in the poorest region. One study from Kenya found that 2.8% economic growth rate per year was halted by this single disease alone. Where you look at the teachers, the doctors, the lawyers, the leaders are picked off at a young age, and it's devastating to the economies. And that's happened all over the world. Trade. Another very complex subject that's largely invisible to us, but just a couple of highlights. Oxfam has said that global trade is like a hurdles race in which the highest hurdles are placed in front of the weakest runners. And the reality is this. You look at the Farm Bill. It's part of a $350 billion annual subsidies that rich country governments give to their farmers. We do that. We pay our farmers money so they put their commodities out in the world markets at a reduced price. Farmers in Brazil, not Brazil, but Vietnam or El Salvador or Uganda can't compete with this. That amounts to $350 billion a year. When you add to $50 billion in tariffs, you're creating a $400 billion barrier against poor countries exporting their goods. That's a problem. And when people in poor countries say, hear us say trade, not aid, they scoff. They wonder about this. Now, there's a lot more examples you can get into, including the debt crisis, history, racism, etc., that some of these other books, like Guns, Germs, and Steel and other have gone into. And I summarize all these here, but let me just summarize it as follows. The simplicity on the far side of complexity. That's the complexity. And the simplicity on the far side is this. In my experience in the world, in many poor places, I've seen hardworking and lazy, good and bad people, but for the overwhelming majority of poor people in our world, the forces aligned against them, these forces are utterly insurmountable. They're utterly insurmountable, and that's the reality. Let's take a break from that and get down to the micro just for a minute. This is Philip Kiemu. Philip was a 12-year-old kid in Nairobi when I met him in the mid-90s, and Philip grew up in Kibera. Kibera slum is home to 800,000 to 1 million people, nobody really knows, living in abject poverty. It is a brutal place, it is a dangerous place at night, but every morning you look out here and you see a stream of people in immaculate clothes going off to work in the farm, in the industries all around Nairobi. Now, Philip grew up in a hut, and his mom died of AIDS, and Philip became an AIDS orphan, one of 14.8 million in Africa right now. And this is Philip's hip. You can see the moth-eaten appearance. That's osteomyelitis. Philip lay on a floor in a mud hut in Kibera with this hip and was really close to dying when he came to St. Mary's Hospital in Nairobi, run by Bill Friday, which we'll talk about in a minute. And this is Andrew Kimaku. This is Ed Wyman, an orthopedic surgeon and a good friend who passed away a couple of years ago from Mass General. And Ed was over there training physicians in Nairobi about surgical technique. And this was something that is an important thing to do, I would argue. Philip is now a kid, went to the orphanage, he's able to get around, his life was saved. It's a great story. This is what our profession can do. It's a great story about a little vignette about global health service. But I want to make the following point, and just from looking at the lectures earlier today. What we do, what you do, is nothing short of miraculous. Try and envision your grandparents, anyone's grandparents here, getting a glimpse into what we can do medically in 2013. It simply is miraculous. And the fact that we can turn a case like this and have him walk again and thrive and have a normal functioning life is incredible. But our great noble profession has, at least in my opinion, an Achilles heel. That our knowledge and talents remain concentrated among those who can afford them. And that's something that I think compels us to act and calls us to engage more than we have. Now, why should we respond? So kids are dying in Africa. Well, kids are always dying in Africa, right? Why should we care? It pains me to answer this question. I think those of us in this profession, you hear the compassion like in the hospice talk this morning. You hear the compassion and you see it and feel it among your colleagues. Why should we even answer it? Well, I think it's imperative that we do from a historical perspective. And I can take a number of tacks in looking at this, but let's start with Schweitzer. Again, Schweitzer said we have an ethical imperative to care for all people, not just those in our traditional realm of concern, and I think he's right. There's also a faith-based rationale. And any place I've been in the world that's had abject poverty, I've always found faith-based groups there, always. This is one of my favorite people. This is Gustavo Gutierrez, the founder of liberation theology. He said this: if I am hungry, it's a material problem. If someone else is hungry, it's a spiritual problem. There's also the human rights paradigm. It started with FDR's State of the Union speech on January 6, 1941, when he talked about 4 freedoms. Now, roughly 4 years later, when he passed away, his wife, his widow then, Eleanor Roosevelt, led a small band of dreamers at the fledgling United Nations and crafted what is arguably one of the more important documents ever written, the Universal Declaration of Human Rights. And this document, I encourage you to read it. It's in the back of my book. You can look it up online. This essentially says this: by merely being born into the human race, we all have basic rights, among which includes opportunity for employment, for education, for life of dignity, lack of imprisonment, lack of racism, and the opportunity for health and health care. And this argument states that if those rights exist for all of us, doesn't it therefore mean incumbent upon those of us on the wealthier side of the equation to make sure that those on the poorer side of the equation have access to those rights? And a lot of NGOs have adopted this paradigm. It's become incredibly popular and important. Now, finally, if the religious or faith-based or Schweitzerian or human rights paradigm don't do anything for you, there's always what Oxfam terms enlightened self-interest. Do these things because it's important for us. There's no question that poverty is a major driver of security concerns. A 1994 CIA study found that between 1957 and 1994, 113 cases of U.S. military engagement, every one of them occurred in failed states. Think Somalia, Afghanistan, Sudan. These are sites of drug trafficking and refugee movements and infectious disease outbreaks and terrorism. This always ensnares our military, so it would behoove us to help these people grow. Poverty and infectious disease outbreaks. There's a wonderful book by Laurie Garrett called The Coming Plague, in which she outlines these epidemics and how they started. The story of HIV is instructed. Following Idi Amin's rampage in Uganda, that was one of the sparks that set this HIV on fire. And if you're an opportunistic pathogen, you love nothing more than to find a concentration of huddled people immunocompromised because of starvation and poverty. And that's something that is clear. Now, climate change. I know there are some who question the science of climate change, and I only could say I wish you were right. The problem is there's a mountain of data that says that this is real and this is devastating. I just copied this and pasted it in. This is from the New York Times last Friday. And some of you I know have seen this already. Last Thursday, the Mauna Loa Observatory in Hawaii recorded for the first time in human history the CO2 parts per million go over 400. The last time that happened was 3 million years ago. Now you can see the snows in your mountains here. I climbed Kilimanjaro when I was 27. There's no snow up there soon. This is real and it's a real phenomenon. Why do we care in a global health talk? 2 reasons. One, when ocean levels rise, when the Sahel region dries out, as climate changes, you have populations on the move. You get migration, you get conflict, you get war. These are the wars our children and their children will be drawn into. That's number one. Also, in that same vein, it's the poor who will suffer most, as they always do. Number 2 is that the poor are actually drivers of this. And let me explain in a second. Right now, the world population is about 7 billion people. It's estimated it's going to be about 9.6 billion by 2050. 98% of population growth in our world occurs in developing countries. 98%. Why? Not because that's just what they do over there. And again, the simplicity on the far side of complexity says this: the poor have a lot of kids because they don't have safety nets. When I go to Uganda, there's no Medicaid, there's no Medicare, there's no Social Security, there's no safety net. When you get old or sick, you do that by having more kids. You have more kids because kids die at such rates as they do now. You have to have someone there to care for you when you get old. That's the reality. We address these issues of poverty and help these countries rise up. Again, a mountain of literature shows as incomes rise, as education improves, particularly for girls, and as health improves, population size and fertility shrinks quickly. We address these issues, we ignore these issues at our peril. And unfortunately, these are very, very real and very concerning. Now, from the perspective of the healthcare worker shortage, this is another thing. There's a real good rationale for why we should respond to this. And again, there's 1.5 million health providers short in Africa, and there's a desperate need for us out there in the world. Now, let's just look at the rationale for this. First of all, 20% of the physicians in this country come from other countries. That's good news for us. We welcome them, we need them, and demographic trends show we're going to need a lot more of them in the future, which is why we just built 13 medical schools. But the problem is, how fair is that if we take a physician from Pakistan or a poor country that puts all the money into training that physician and then they come here? Doesn't really seem fair. Secondly, there's a huge interest. This is a very, very big area in medical schools, which we'll see in a minute. A lot of people want to do this. Third, there was a study in 1999, the Millennial Study, which is the largest in human history, where they asked people what they valued most. Health was by far number one. And then finally, I just direct your attention to the ship in the background on this slide. That's the Comfort. That's in the Atlantic. On the Pacific, it's the Mercy. These are U.S. Navy ships. And these photos here are health providers who responded to the earthquake in Haiti in 2010. And over here, some will recognize Tom Dooley. This is perhaps one of the most underutilized, but most potent smart power weapons that we have at our disposal. And the reports from our health personnel going into the tsunamis aftermath, and I believe it was 2004, or in Haiti, gets more goodwill for this country than any other thing we can imagine. It makes sense. And just as a parenthetical point, the COIN strategy, counterinsurgency strategy, one of the many reasons the Iraq war turned was because David Petraeus came in and said, we're going to institute counterinsurgency. Counterinsurgency is all about winning hearts and minds. That's how Iraq turned, that's how you win wars, that's how you influence people, and there's perhaps no better way to do this than this. Now, solutions. And I love this quote from Camus, painful though it may be when you look at historic solutions to what have we done about this? We've known about this forever. And the whole foreign aid and addressing these things really originated in the 40s, in the late 40s, at the end of World War II. But Camus' quote is unfortunately telling. The evil in the world always comes out of ignorance, and good intentions may do as much harm as malevolence if they lack understanding. Again, one of the reasons I spent 10 years writing Awakening Hippocrates is so we get the critical reflections in our mind and understand this realm before we dive into it. We as a country, we as a people, and we as a profession have done this time and again, unfortunately. Now, I'm not going to spend too much time on this, but it is important. We've done a lot of things through time. The United Nations, eradicating smallpox, the Gates Foundation, which has given $1.7 billion since 2006 alone, NGOs, religious groups, corporate groups, universities, a wonderful response, but the bigger ticket items really probably is this. Now, foreign aid gets everybody's blood pressure boiling, and I apologize for that while you're eating. But it is important to at least look at this briefly. The United States gave $31 billion in 2011, about $30.4 the year before that. And this is a quote from JFK that says this: foreign aid is a method by which the United States maintains a position of influence and control around the world. That's what foreign aid does from the government standpoint. That's not how we think of it, though. When you look at surveys from the Program on International Policy Attitudes at the University of Maryland, they've been surveying this for 30 years. People in the United States want to give more. We want to help people in other countries. We always have. Think of the Marshall Plan. We've always been there. We've prided ourselves in being that city on the hill that can reach out to the world, provide an example, and lift others up. We want to do that. Population surveys support this. We want to alleviate hunger. We want to increase aid to Africa. And unfortunately, when times get tough, we want to cut foreign aid. But that's one of the many paradoxes in this realm. When people are surveyed, how much of the federal budget goes to foreign aid of the U.S. government's budget? What percent is it? Surveys consistently through time have said 15%, 20%, 24%. Imagine that 24%, 1/4 of our budget to foreign aid. And most people think we give more than any other country per size of the economy. That's what we think. Let's look at the facts. Well, the reality is the United States gives more than any other country in the world by far. No question about it. $31 billion in 2010, we're way ahead. But here's the problem. The way the world views this, it's not just the amount of money. The United States economy is 25% of global GDP. No one is even close to us. So the way the world compares, they divide the amount of aid given, the ODA, Overseas Development Assistance, by the size of the economy, gross national income. Then we come out a little bit close to the bottom at 0.2%. That's not what we necessarily think, but that's the reality. Now, if you look at what we've done over time, here's the Marshall Plan, the late 40s. Since then, the amount has come down, and we've stabilized at about 1%, less than 1% of our federal budget for the last, 40 years, 40, 50 years. That's where we are, and that's the reality of what we are. This slide very quickly makes the point of global aid, overseas development assistance from the world. The number's been steadily going up. Big spike after 9/11, continues to go up. When you divide that by the amount of income, it goes down. We don't do what we think we're doing. The business of aid, there's a whole genre of books, and some of you have probably seen these. Really the most eloquent and critical of them is this one, which is hard to get now, but it's a brilliant read. You've probably seen or even read some of these books, and let me just summarize this for you briefly. From the standpoint of the poor, historic foreign aid has been a disaster when viewed from the perspective of the poor. Not recently, which we'll get into, but historically, from the 40s on to about the 90s, 80s, 90s. But here's the reality. Foreign aid, as JFK said, is really not about helping poor people. That's what we think, but that's not what it is. Foreign aid has historically been about rich country governments and meeting the political, economic, and strategic interests of the donors. That's what foreign aid is. So we don't always think of it in terms of poor people. But things changed, and things changed fairly dramatically in the 90s. This is a great book, not that long, 130 pages, called Macroeconomics and Health, that Jeffrey Sachs wrote. And this is a book that summarizes a lot of this and just is much more approachable if those of you who want to read it. But essentially what Jeff Sachs said is, if countries want to get out of poverty, if you want to change these things, they have to grow economically. Look at China and India. Poverty is plummeting in those countries because of economic growth. But the problem is, if you look at places like Africa, and all what we've just been looking at, if you have a sickly population, they cannot drive the engines of industry. You can't grow economically if kids are dying at that rate and people are that sick. So what Jeff Sachs said is, well, why don't we pump a little more money into global health? And he was out making the case years ago, and these numbers are simply staggering. If you look at the 1990s, we were giving very, very little, almost nothing to global health. Numbers came out, data came out, and then to the Bush administration's credit, a lot of this is PEPFAR, the President's Emergency Plan for AIDS Relief, the largest single one disease response in human history, and the President's Malaria Initiative. These are enormous bumps. We're at the point where last year, the United States government gave about $10 billion to health, and that's huge. And you can see here's where it breaks down. Most of it is to PEPFAR and PMI. And again, when you look at the federal budget, it's still a tiny percent. It's not a lot, but it's incredibly effective, and it is changing things. Now, this is another fairly complex slide that goes into a lot more detail. It just breaks things down a little bit more. Because people always ask, well, that's what foreign aid is. That's what our government is doing in terms of foreign aid. But where's the money coming from? Where's it going? This breaks that down. Foreign aid is only 9% of the total of what goes out of the United States every year. Philanthropy, and it's all these things, the volunteerism, universities, church groups, foundations like Gates. Probably most of this is Gates. That ends up being about 12%. The big money is down here in these last two. Remittances. Remittances are the money that are shipped back home from people who work here. Now, I can tell you, in the emergency room where I work at St. Elizabeth's in Boston, we have staff from Guatemala, El Salvador, Mexico, and Haiti. And I know them all well. They're very good people, and every one of them is working more than one job and sending a lot of money home to the tune of $95.8 billion a year. That's what people do. You get in a cab in Boston, I always make the point of talking to people and asking. And I would bet you that some of the people working here today and cleaning the rooms upstairs are doing actually the same. That's a big source of income, and that's a great thing that we can do that. We're not doing that. They're doing that. But here's the next phase, and this is where half of the money going out of the country is. About 100 million of this is your stock portfolios, your 401ks, 403bs, money that's free-flowing around the world that seeks profit. That's one, and about 50 billion of that is foreign direct investment, money that people are sending to developing countries to try and grow industry. Hugely important in places like Africa. Now, I don't want to leave you with the idea that things aren't going well there, that things aren't improving, because things are really changing fairly dramatically. And this slide shows that. First of all, this is a wonderful book by Steve Radlett. I apologize it's not as clear. But this book talks about 17 countries and how rapidly they're growing and how rapidly they're changing. The aid dollars that have gone traditionally in the past that haven't worked, things are changing. It's much more is going into health and infrastructure. And there's a lag, but some people talk about Africa as being the next China, the next India. And the World Bank is predicting economic growth rates of 6% per year for the continent, which is pretty staggering. And this actually shows that a number of countries are actually ahead of making the Millennial Development Targets for infant mortality. So, contrary to the bleak picture I've painted, those things exist right now. The trajectory looks good. And to summarize this piece before we move on, there's improvement in the world, but there's still enormous need and a lot of need for us. But here's the fundamental question, and this is the key question that I challenged each of you. And this is really what I want to try and focus on in the remaining half hour or less, 20, 25 minutes. What can I do about it? We have a room filled with health providers. Any one of you could take your skills, I don't care what your area is, anything you do, pediatric neonatology, there's space for you. Neurosurgery, there's a great neurosurgical organization. The surgeons, I was really honored to see so much going on in this area. There's space for everybody here. But I want to start with this piece here. What have we done about it? Well, this shows you. If someone were to ask right now, how many physicians and nurses left the United States last year to go overseas? Nobody knows. That is an answer to which nobody has a question which nobody has a response right now. And the reason is, Fitzmullen, who I'll show you in a minute, he and I have tried to do this study for a few years, but we've been unable to get funding for it. The only literature we have is from Tim Baker from Hopkins in 1984 that said that 1 in 300 physicians, 1 in 1,000 nurses went overseas in the year before the study was done. Now, we know those numbers have come up because the AAMC surveys medical students every year, and those numbers have gone from 6% around the time I went to 30% in 2009, around a third now. So more and more people are going and are engaged. Isn't enough. And I love this quote from Dr. King, whose name I notice is the street that we're on right outside here. He said this: the racial problem in America will be solved to the degree that every American feels himself personally confronted with it. And there's no question that race relations in the United States have improved dramatically, in part because of Dr. King's work. But we could say this analogously, that the problem of global health inequality, that too will be solved only to the degree that each person, particularly those in the health professions in the United States, feels personally confronted with it. Now, I've been doing talks like this for a lot of years, and I know I can get you to think, but I can't get you to feel. Only direct experience with the poor can be enough to change hearts and minds and redirect courses. And now when people make the decision that they want to go overseas, we've got some pretty good icons and pretty good leaders that we can look up to, right? Anybody know who this is? That's Paul Farmer. Paul Farmer is a unique force of nature. Like Schweitzer, he sleeps about 3 or 4 hours a night. I have no idea how he does it. Just an amazing guy. In addition to teaching the world about how to treat HIV and MDR-TB in resource-poor settings, Paul's done something I think far more valuable. He certainly has been a major influence on me and a number of other physicians in forcing us to confront underlying causality. Why things are as they are in our world. And Paul wrote years ago something that always stuck with me. He said, when my patient comes to me and says, I'm sick because I lost my land, doesn't that force a physician who truly cares and wants to engage their patients to at least think about why. Is it world trade policies? Is it the US Farm Bill? Is it local government interactions? What are the component forces that cause these things? And that's a very valuable contribution. He's an icon and an incredible person. This is Jim Young Kim. I had the good fortune of doing a fellowship with Jim, that Kellogg Fellowship in the 90s, and got to know him pretty well. And maybe I'm name dropping a little bit, but here he is with the president being nominated as the World Bank president last year. But what Jim said, Jim was always a big picture guy, always looking way down the road. And I love this quote. As much as I hate to read a quote to you, this is worth reading. He said, what's become clear to me is that delivering on ambitious social goals requires more than principled individual action. Think of Albert Schweitzer, which pioneers always have to be that way. But we're in a new era. He said, it requires building and implementing systems that can deliver sustainable solutions. And I'd love to get your heads around this as we enter into this world of engaging the poor. We're in a different era now. We have Skype, and we have the internet, and we have jet travel, we have global communications. It's a whole different realm. And if you can do this in a sustainable way, that's the way to do it. This is Bill Frieda. Bill Frieda is a priest I wrote about also. He's a Mayo Clinic trained oncologist, and he's been in East Africa for over 35 years now. Bill built St. Mary's Hospital. This is St. Mary's, where the slides I showed you earlier. I took this picture of the Kibera slum from the water tower at St. Mary's. A sustainable system built with Kenyans. There's another hospital they built in the Rift Valley, and the goal being to triangulate the care where by the end of the next decade, he's hoping to have half of Kenya's population in this system. Pay as you go, affordable, even to people in the slum. It's $1 to see a physician. The poor can't afford this. It's affordable, high quality care with dignity. That's just a wonderful model. And these are two people I wanted to introduce to you very briefly. Some of you may know. This is Fitzhugh Mullen, who's a professor at George Washington University, and this is Vanessa Carey, who's at Mass General and Harvard Medical School. MEPI, the Medical Education Partnership Initiative, is the work of Fitz Mullen and his colleagues at GW. This is a $130 million NIH initiative in which 13 US medical schools are partnered with 13 medical schools in sub-Saharan Africa to enhance training. This is brilliant. Fitz Mullen is the Abraham Flexner of Africa. And the SAM study, the Sub-Saharan Africa Medical School Study, is online, it's in Lancet, it's wonderful. It documents for the first time what is medical education in Africa and how do we change it. That is a huge program that's going to reverberate for generations. Now, Vanessa Carey came along and took this idea of a physician Peace Corps. This idea that goes back to the 70s with many, many iterations and many, many failures. And Vanessa came along, got a really impressive group together assembled right here, including Eric Gooseby and Aaron Williams of the Peace Corps, Buck Buckingham, and that's Fitz, and basically developed what is called the Global Health Service Partnership and Global Health Service Corps. This is a program that you need to be aware of. The Peace Corps has finally entered this realm. It's been, and Peace Corps is a wonderful organization. We work closely with the Peace Corps in Uganda. But the Peace Corps now has, as of this year, a physician, nurse, health provider piece. Starting out with, I think, about 10 volunteers this summer, where people go in for 1 year at a time at a MEPI partner site, right, somewhere in sub-Saharan Africa. And the plan is to expand this over the next 5, 10 years to include up to about 500 people. So those of you who are thinking about longer-term 1-year commitments, this is a brilliant model. I know it's been a lot of difficulties. I saw Vanessa when I was in Uganda. She was there then. That's one of the sites. But it's just a phenomenal thing for them, a phenomenal advancement. Now, most of us can't become Fitz Mullen or Bill Frieda or Albert Schweitzer or Paul Farmer. And as Paul Farmer once said, I never said this is how you should do things. I just said these things should be done. Because it's daunting. We look at Schweitzer and think, well, I can never do that. I've got 3 kids. I've got looming college tuitions, God help me. We all have these obligations at home, and it's very hard to do what they do. But there are other ways that we can do it, and I'd love to share this example. This is Joe Bowles, an ophthalmologist I knew for many years at Leahy North up in Peabody, Massachusetts. And what Joe did is more attainable. For 1 week a year, 1 to 2 weeks every January, Dr. Bowles traveled to El Salvador, worked with Dr. Vicky Guzman, and over a 25-year period, they built what is one of the largest ophthalmology institutes in El Salvador, the Clínica de Ojos. And he did this by bringing supplies, resources, staff, and helping train people That's something that we can do. That's something that's more attainable. Okay? Now, I share my own organization's work with great humility. What we have done is nothing compared to what they have done, or even people right here in this room have done. But I want to just share what we've done and my thinking, because that has changed the longer I've done this, which is now over 15 years. Since 1998, we've been sending physicians overseas to do training. And I think if you do something overseas, if there's an education component to it, it's sustainable. You leave something behind when you teach people in developing countries. And I love this slide for its simplicity and the power of what it represents. This is Don Aceta. We ran a program in Belize for 10 years, traveling grand rounds. Don is a local allergist, lives in the Boston area. And these are some physicians right on the Guatemalan border in Belize. This is Lesbia Guerra, Gil Pais. And Lesbia became really interested in asthma. And that's what Don was teaching. Spent a lot of time with her. She developed asthma clinics and went all around the area. And then they started noticing the kids were in school more, kids were sick less. It's the value of transmitting education in developing setting. Now, we've done this in a number of countries. This is Guyana, John Varallo. This is John O'Brien, a radiologist teaching students. Peter Mogilnicki from Dartmouth at Georgetown Public Hospital there. And again, John Varallo. Now, John Varallo went out and developed another program. And this is, again, the power of exposing talented, compassionate people to these settings. John went to Guyana, and he noticed that there was no cervical cancer screening program available. So John set up to develop one. He developed a model. It became the national model of Uganda, and he took the program to Jipaigo, which is, we have no resources. Jipaigo has great resources, and that's what it did. That became a national model, and now they're doing it all over the world. And that's his program. Now, I got involved a few years ago in a group from the Brookings Institution. This is Harris Wofford, Senator Wofford, who was JFK's civil rights liaison with Martin Luther King, and he worked with Sergeant Shriver in the Peace Corps. He was his right-hand man. And this coalition of people came together to develop really an international volunteering perspective, to try and lobby Congress to get more federal dollars put into this realm. And I got involved because they asked me if we could develop something in sub-Saharan Africa. Now, if you look at service, if you look at volunteerism globally, if you do a literature search on this, you'll find a large number of studies that look at the impact on the volunteers. And there's no shortage of data. Volunteers go to developing countries, it changes them. It always changes them. Those who go with hearts and minds get changed. It happens invariably. The bigger issue is, what about the evidence of impact? And there's a real paucity of data that these programs make an impact. And that's what we set out to do. We said, can volunteers fill this gap? And we set out to develop programs somewhere in Africa that would be sustainable, scalable, would use health and non-health volunteers, and would measure the impact. So that's pretty much what we did. We went to Uganda. This is Uganda here. That's an old slide. That's DRC, Tanzania, Kenya, Sudan. And we worked right over here in the Mukono area. This is Kampala here, and we are based right here in Ntenjeru, and we have this area here. This is the area where we work. And essentially what we do is we train VHTs. Now, a VHT is a village health team in Uganda. It's a community health worker. And the reason that community health workers are so valuable there is less than half of Uganda's population lives within 5 kilometers of a health center. And when they do get to the health centers, they have stockouts, there's no physicians, there's no health staff. It's not a great situation. There's models from all over the world, including Paul Farmer's Partners in Health, Millennial Promise in Kenya. Ethiopia has a wonderful model that shows that community health workers can really deliver preventive and treatment care. Now, the program that we work in is not ours. This is the Ministry of Health's program. Again, getting back to Jim Kim's comment. We come in and we help facilitate it. We've sent about 50 volunteers so far. And what our volunteers do is they facilitate these trainings. And it's a wonderful experience. They get a lot out of it, but more importantly, they leave something behind. Now, this study makes the case for why this is so valuable. If you look at rural Uganda, where this work takes place, there's no hospitals there. There's very few health personnel. As you can see, there's no doctors, very few. But if you want to save lives in the rural areas of our world, like Africa, it's actually home-based care from the study at USAID that makes the biggest change, right? 2/3 come from basic community level interventions. And if you want to look at the specific type of thing, it's oral rehydration therapy and breastfeeding, antibiotics for pneumonia, insecticide-treated nets to prevent malaria, water, sanitation, hygiene, tetanus. It's basic stuff. This isn't rocket science, but it is by far the most effective way to save lives in the developing world. So in our program we have medical students, and we've had physicians, nurses, PAs, 2 college graduates, one that had done multiple tours in Iraq who was well seasoned, another had done a lot of international experience. But basically to take people over, that's me giving a talk here, training these wonderful community health workers. We've worked closely with the Peace Corps. This is Zach Tabb, a Peace Corps volunteer, worked with us for 2 years, who just got accepted to Brown Medical School, where he starts in August. And these are some residents from St. Elizabeth's, where I work, a 4th-year medical student. We also, once we train them, we maintain them. And we maintain these community health workers by doing quarterly meetings. 4 times a year, we bring them all together, update them, do different topics. And then we have focus groups, where we introduce different subjects. Now, on the basis of our focus groups, these are students from the UCSF that did a water project. Now, one of the things we did was to look at the water. This is the water source. I took this picture in March, just a couple of months ago. And this is the source. These are jerry cans, and these are another site. This is where a lot of Africans get their water. If you did time-lapse photography, you would see a cow coming down to drink here, and maybe defecating and urinating in the water, or in pigs and other livestock. And people as well that don't have sanitation, they don't have toilets. So it's easy to see how people get sick. And what we started doing is building protected water sources as well. It costs about $500 to build one of these, but you can see the difference in the quality of the water, that one from the one before. It's quite a difference. And we've done studies in this. It's 50 times less likely to contain fecal coliforms. Now, this is a very complex and busy slide, but it makes a fundamental point I think is really important. We think of pneumonia, or any disease, mortality, of most likely it's antibiotics or it's vaccination, right? Those are the big things you could do for pneumonia. But we all know intuitively that the immunocompromised cancer patient coming into this equation, this fight with the microbe, is far different and going to have a far different outcome than the strapping 24-year-old. Similarly, in sub-Saharan Africa, if you've had diarrhea continuously, resulting in stunting growth and immunodeficiency, if you've had continued battles with malaria because you don't have ITN, and those are based on hand washing and sanitation and water and basic things, any one of these things, improving one of these things, should improve your mortality and from pneumonia and many other diseases. In other words, it's all tied in. The more you can improve the basic things, the more lives you can save. And that's essentially what we've done for the last 5 years. And just at this slide, I'd like to just pause and say, anybody here who wants to join us, who wants to spend a month or 3 weeks or 6 months in Uganda working with us, you're welcome. You're all welcome to join in this project if anybody wants to. And essentially, we don't do all the training. About 80% of the training is done by Ugandans, as it should be. We facilitate. We do most of the quarterly meeting training, and we do home visits. We hand out sheets that have, in the Ugandan language, how you stay better. But that's basically how this works. We've trained almost 1,000. We'll pass 1,000 next month, and it's been an interesting project. Now, I can stand up here and say, hey, what we're doing is great. We go to Uganda, we train these VHTs, they make an impact. But like the officials in the Obama administration said to us right in the beginning, well, how do you know? And what I would challenge all the NGOs that work in this realm is, how do you know? Where's the data? Now, it's great to know that from Ray, Dr. Price, and Dr. DeVries, that there are some studies that are going on now, which is wonderful. And I hadn't realized that you guys were doing that, which is great. But again, the literature is really not there yet to make the case that volunteerism can do what we know it can do. So we set out to do a randomized controlled trial. And what we did is went to Uganda, and I'm sorry, we cobbled these groups together. Peace Corps has been right in the middle of this. And if it weren't for Zach Tabb, our Peace Corps volunteer, none of this would have happened. We have very little funds at OmniMed, and we've really relied on all these groups to help support, not financially, but in fact, none of these groups have given money. We've raised that from our volunteers and our donors, but we've put these groups together. And this is what we did. We randomized these 2 parishes, Sai and Terere Parish. The pink areas are the areas where we ran the program in here, and the white areas are the areas that served as control. not in Tansy Parish. We wanted to separate, because this is Lake Victoria here. Malaria incidence is much, much higher anytime you get close to a body of water. And here's what we did. We set out at the beginning of the study to ask basic questions: hand washing, sanitation, health behavioral issues, vaccinations, use of antibiotics for pneumonia, use of anti-malarials within 24 hours of a febrile illness. And we asked people right at the outset in both the impact, intervention, and the control areas at the baseline, so we could get an idea of what the health behaviors were. Then we did the program. We ran the program in the intervention areas for 1 year. Training, quarterly meetings, home visits. Every household got the prompts, which is pictures and words in Luganda that summarizes the most important preventive strategies. And then a year later, we conducted the same survey. And here's what we found. This is by the way, how the surveys was done. So you think about a study being done in the US, this is how we did it in Uganda. This is from Uganda Chartered Health Net. They had PDA drop menus, and this is a very typical Uganda household with a lot of kids. And these are the questions that we asked. 98 total questions, and the numbers here respond to how many questions were in each realm. And these, again, it's nothing complex here. It's water and pregnancy prevention, antenatal care, and family planning, nutrition, use of ITNs, et cetera. It's basic stuff that, again, from that earlier slide, shows how you change mortality. And that's what we found. I'm not going to spend too much time on this because I know we have to wrap up fairly soon. But let me just show you this. First of all, Zach and Pete Acker, a Tufts medical student, developed this study where we looked at pre and post training, day 1 and day 5. What did they learn? Average scores went up by 14%, so we know we're getting through. This question: have you been to a health center for the past 6 months? The control group, not so much. The intervention group went up, and that is statistically significant. Water: people in the intervention areas were more likely to boil their water. Again, statistically significant. Now, we had a lot of problems in this trial, which I'll show you. ITNs, more people in the intervention group than the controls were likely to be hanging their ITNs and using them. Knowledge. This slide shows to one of the biggest problems that we had. Now, the good news is that in all areas, the malaria rates went down, baseline to post-test. They went down pretty much. And the time of year was exactly the same 1 year to the next. Malaria rates were about the same. It wasn't like there was a rainy season and a dry season. It was the same time each year. And here's what we found. The malaria rates went down. More people were seen in a health facility. More people had access to antimalarials, including Coartem, which is the drug of choice. Now, what we found from the study was there was a huge amount of bleeding from the intervention area into the control area. And that's our bad. We couldn't control where we did because we only had a very narrow area that we could restrict other NGOs and other ministry programs, but we did see a lot of bleeding. Far more people were likely to consult a VHT. Pneumonia rates went down, if you remember that earlier slide, far more in the intervention area. And people generally were doing something to avoid pregnancy. Again, addressing this challenge of climate change and population explosion. And this is a summary slide that really looks at where we are. Generally, something fairly significant happened in this area, both in the intervention and control areas. And we have data, we're going to publish this. We have data that shows that a pure volunteer service program using health volunteers from the United States, partnered with VHTs who are volunteer, with Peace Corps workers who are volunteer, that this program can work. But let me just close with this piece before I get into one last piece on this. This, I think, is an important direction for service. And I was just saying before we came up here to a small group that if we want to get funding and more of us an ability to go overseas, you have to have data. The reason that $10 billion from US government funds goes to global health every year now is because there's great data that shows that you hang up ITNs, it works, it cuts down malaria. 1 million kids in Africa die every year of malaria. That cuts the rates dramatically, and in the whole community. Measles vaccine campaigns work. Nutrition programs work. There's a whole slew of things that are done smartly and done well. We have to come around in the service sector to make this work. Now let me close with this final piece in the last 5 minutes. I would encourage all of you to really think about this. Really think about engaging in this realm. I've known so many providers that have said, of all the things I did in my professional life, nothing compares to the work I did in X country. wherever it is. It's incredibly enriching, incredibly rewarding. And one of the things that happens that's a common theme among those that do this, and I know this is true in Paul Farmer's case, I got to know Rena Schweitzer before she passed away, and it was true in her father's case as well, is that transformation happens. People are changed by this experience. And I think to better understand the concept of transformation, we look at some people that we all know and look at how it affected them. FDR was 39 years old, Assistant Secretary of the Navy, when he was swimming in a pond up in Maine when he contracted polio. And from Eleanor Roosevelt's recollections, he would not have become the compassionate president he was, the initiator of the New Deal and Social Security, had he not suffered the way he did. Bobby Kennedy, similarly, he was a tough SOB as the Attorney General. He was not popular. He was in your face, he was aggressive, he was not liked by a lot of people. And then his brother got shot. And Bobby Kennedy went into a deep melancholy that he wrote about. He read a lot about the Greek poets. He took time off. He really changed. And here's a quote that he read. One of his favorite poets that he quoted, in fact, this is written on his graveside. I was just in Arlington with my kids 2 weeks ago in Washington, D.C. And this is the poem that he quoted, the quote from Aeschylus that he read the night Martin Luther King was shot in Indianapolis. He said, "In our sleep, pain which cannot forget falls drop by drop upon the heart, until, in our own despair, against our will, comes wisdom through the awful grace of God." Now, change isn't always easy. It's hard. And when I first went to Tanzania, I heard things about my government that I just didn't like, I didn't want to hear. We do wonderful things in the world, but we haven't always done the best things. And these transformational changes can be difficult. Now, Colin Powell and Bono, like Bill Gates, like others that have been to Africa, seen AIDS, have been profoundly changed by it. And Colin Powell said to people right after 9/11 happened, that were working on the Global Fund, he said, no matter what happened at 9/11, you keep pushing forward. You don't let the Global Fund go. And they didn't. And PEPFAR has really become a huge program. And similar with Bono. Bono's been a huge influence, as has Jeff Sachs. Now, more germane to our story here is this guy. This is Tom Dooley. And Tom Dooley grew up in St. Louis. He was a wealthy aristocratic family, and his goal was to become a society obstetrician. Went to medical school, went into the Navy, became in charge of Operation Safe Passage, getting the heavily persecuted Catholics out from North Vietnam, away from the communists, to the South. Now, the experience changed Tom Dooley. He said he saw these people, their magnificence, their dignity, their grace under incredible, impossible circumstance. It changed who he was. Tom Dooley wrote books about his experience. He wrote 3 books. He became an icon in Eisenhower America, one of the 10 most admired men of his generation, according to Reader's Digest polls at the time. Now, Tom Dooley ended up contracting malignant melanoma and died at the age of 34. And the end of his life was a resolute struggle against poverty and suffering in Southeast Asia. As he lay in state at St. Louis Cathedral, his good friend John F. Kennedy was being sworn in as President of the United States. And Kennedy said about Dooley that he was one of the inspirations for the Peace Corps. Now, Tom Dooley's lesson, I think, is instructing for all of us. He was a brilliant, charismatic man, a showman, a true showman, and a good writer. But Tom Dooley's story is this. He was brilliant in some ways, flawed in other ways, but his story is one of the power of transformation. If an individual like Tom Dooley can go to a place like Southeast Asia and have his heart and his mind open, he's amenable to change and to being completely transformed by the experience. And I think that one of the most potent weapons that we have in this fight against these inequalities, this unconscionable suffering that defines our world still, is the power of the transformed. That certainly is Paul Farmer's story. It was Albert Schweitzer's story, and it's most people in this realm who give a lot of time and energy into this, the power of transformation. Now, I've written 2 books to try and get people to think more critically about these issues. Awakening Hippocrates covers a lot of what we covered here, the why things are as they are, and then the Guide to Practical Health Service to help get you there. That's what those books are for. And to quote Gustavo Gutierrez, again, the first act for those lacking the privileged experience of working among the poor is not a head trip, but a foot trip. You just got to get there. Now, if you look on the OmniMed website, we developed this Center for Global Health Service. And we tried to make it easier for anybody, whether it's physician, nurse, PA, anybody of 26 allied health professional areas to get overseas. So you can actually go on the website now, look for this icon, start searching, type in your specialty, where you want to go, the continent, the region, country, and duration. Now, I apologize. This is several years out of date now, because it's expensive to maintain and we haven't had the funding to do it. But it's still, you can go on it today and you can find a list of organizations looking for your services, and that'll get you over there. Let me just conclude with this. There's been a lot of solutions to this, the challenge of global health inequity, and there's a sea change going on right now. Traditional methods that haven't worked very well are changing, but there's still a lot more that we can do. I think all of us can do something. We all can and we should. And again, I'd extend my invitation to any of you to join us in any way. We certainly accept help in any form, and I'd welcome anybody that wants to do this. I also think we only change things with direct action. More understanding, more action comes from those who go and come back. And I love seeing books like this, Global Surgery and Public Health. Congratulations, Drs. DeVries and Price. It's wonderful to see efforts like this. Rudolf Virchow once said, "Physicians are the natural attorneys of the poor. Who else will care for them as we might? Who else knows people intimately the way we do?" I welcome your involvement in this realm. I'm here tomorrow morning doing a smaller session. I welcome you there. And I'm staying for the conference. I love the lectures this morning. I'll be here the next few days. I'd be happy to give my card or to talk to any of you about further questions. I thank you for your attention. I leave my email and website information here. I'll leave you with this quote from Albert Schweitzer, and in whatever remaining time, I'd be happy to answer questions. Thank you very much. Thank you. Any questions? I know there's microphones here. Yep.
A major question I have had about medical care in other lands is language. Mm-hmm. To me, language is such a large part of what I do. How do you do it if you can't speak the patient's language?
Yeah, that's a great question. Everybody hear that about language? In fact, that's when medical students ask me, or college students ask, what's the best way you can do to prepare for doing work like this? It's to study a language. Now, I've worked in a number of countries that have English language. Uganda, they speak English. Kenya, they speak English. Belize, English. Guyana, enough. English is becoming the language of the world, and a lot of doctors in other countries that I've been to have some English training. Obviously, if you can study a language and you know where you want to spend your time, you learn that language over time, that's the best way to do it. I did study Swahili when I was in Kenya and Tanzania and got to the point where I could at least understand the basics. But learning a language, you're absolutely right. It is the best way to get a window into a culture and the best way to do our jobs more effectively. The reality is, for most short-term volunteers, that's not feasible. I think what I try and encourage our volunteers to do, we have a small book on common phrases. And we encourage people to learn basic phrases, because from what I've seen, even basic attempts to learn hello, good morning, thank you, how are you, goes a long way. We rely on interpreters in Uganda. When we give talks, we have interpreters do it. But if you can learn a language, great. Short-term volunteers, not always an option, but even small efforts will help. Yes, other question?
I'm going to perhaps take a contrary viewpoint. It's an open question, not so much necessarily an opinion. 500 years of Christian missionaries in Africa, 1,000 years of Islamic missionaries over the world, 100 years of secular missionaries going around the world, 100 years after Schweitzer in Sub-Saharan Africa, didn't work. Gandhi talked about Swadeshi, that until you build the internal economy to support the values that you're trying to support, all you're doing is creating a colonial system. And if your volunteerism is an export of US subsidized healthcare, and therefore we undermine the market for healthcare in the rest of the world, we actually promote the decline of healthcare by sending out our volunteers. If we cause healthcare to be delivered without a market model in Africa by volunteers, we promote the decline of a healthcare economy that could grow I think the US has an incredible healthcare economy that promotes the number of doctors per patients we have. If we don't promote the economy to drive those things in an internal economy of Swadeshi as opposed to sending in volunteers, we continue to undermine the internal structures and continue to promote the colonialism that has destroyed Africa for the last 500 years.
It's a great question. Very, very good point. I agree with you that historically there's been a much more exploitative and colonial approach to this. And certainly if you read Paulo Freire or read some of the other writers that have addressed this, there's a long history. I guess I would argue, though, that when volunteers go in and train, Africa has one physician for every 5,000 people right now. MEPI, I think, is brilliant. The infrastructure in sub-Saharan Africa for health is abysmal. It just is. And that became very evident with PEPFAR. PEPFAR had suddenly all this money. The United States got on board. And again, that's the best thing that George W. Bush ever did, in my opinion. All this money went out. All these ARVs went out into the world. And then only after that happened did people realize that the infrastructure to treat this incredibly complex disease wasn't there. And that's what led to efforts like MEPI. Now, I think there is a sensitivity that you bring up that's critically important. And there is no question that there are many church groups and there are many NGOs that have much more of an imperialistic approach to this. And that's why I talk about In Awakening Hippocrates. In fact, that's why there's 2 books instead of 1. Because I started out writing a database to get more people involved, and then it became very clear to me from working with groups and seeing good and bad out there in the world, and some that would really build upon the colonialist mentality, where we're coming to help you. We're here to do things for you, the unfortunate. And I agree with you. What Gandhi says is absolutely right. And if you look at what we're doing right now, we're in Uganda building not our program. Our T-shirts say VHT Uganda. You don't see the word OmniMed on those T-shirts. It's a Ministry of Health program. We facilitate their program. Most of the teaching is done by Ugandans. It's all education-based. So your concerns are very legitimate. And if you look at the history of intervention in this realm, there's no question that that's what's happened. And the idea of going into a place and instituting Western ideas, the whole neocolonialism, the whole structural adjustment, the Washington Consensus that happens in the 80s and 90s, was just a continuation of that very problem. Structural adjustment went in because of the debt crisis, and the World Bank and IMF said, we know the solution for you, which in some ways was right. They went into developing countries and said, you have to belt tighten. You have to cut funding to health and education for your people. And it was devastating. Western ideas have not always worked. Indigenous ideas are really the best. And if you look at the other slides I was showing you here, for example, FDI, foreign direct investment in sub-Saharan Africa now, that's going in and helping African companies build up. And a lot of these initiatives now are facilitated. They're partnerships and they're building cooperative structures. The program in Kenya I mentioned, St. Mary's Hospital, about 95% of that staff are Kenyan. If you look at Partners in Health, it's the same way. A lot of the better organizations primarily use indigenous people. And I'm very sensitive to the approach of going in and telling others what to do. And anytime we set up a program like this program in Uganda, we took 18 months of simply surveying the area, trying to understand things before we did anything. And everything we do is a cooperative basis. So your point is spot on, and I really appreciate you saying that because it is something that is not taken into consideration enough. And one of the bigger concerns is a group coming from the United States that says, we have the answer. I know exactly what we need. We're going to go do this. And that's a real problem because the knowledge and the expertise in our VHTs, for example, they know far more than I'll ever know about local illness and local conditions. So we really are far better off by doing cooperative solutions. But I would say that I think that there is a way that volunteers can go and engage, and that's education. Just the knowledge that's in this room right now, if you can connect in a developing country in a way where you're training people, I don't think that's ever frowned upon. I think that's always welcome. And when we have the visual of an OmniMed volunteer, whether it's a medical student, a nurse, a PA, a physician, whoever it is, that really focuses on that one area, and they stand up and they give their talk, and then 80% is given by the Ugandans. That's a cooperative, sustainable structure that's going to last. That's the approach I think is very different from the more imperialist approach that you're citing, but you're right to cite it. Other questions?
Dr. O'Neill, wonderful
Yeah.
talk, and again, thank you for your
Thank you,
wonderful
Dr. Price.
book. It's kind of a Bible that stays in my study all the time, that I refer to all the time, so it's a fantastic book.
I'm so glad to hear that.
There's
Thank
your
you.
plug. You mentioned the human resource problem that we have of very few healthcare workers in sub-Saharan Africa and in many of the low-income, middle-income countries. And there's even an article recently of what the United States and other high-income countries sometimes do that entices these people to leave their countries and to come over here. Yet at the same time, you have a slide that shows that the amount of money they send back to build the economy is actually a phenomenal amount. What is going to be the answer to be able to help provide sustainability in human resources in these countries without disrupting that flow of economy?
That's a great question. Well, to the second part of that, the remittances are never going to change. I don't think remittances will change ever because most of those dollars that go are, as I said, the people that are working in the under economy in the United States, or people even on the black market. Anybody I've talked to that's from somewhere else that's here is sending money home if they have family members elsewhere. So I don't think that changes. And the larger structural issue you raise is really a critically important one. Physicians in Belize, when I was there, made $17,000 to $19,000 a year. Physicians in Uganda make, I don't know, less than 1,000 in the government hospitals. They make nothing. As long as you have incomes in the United States, a physician that can make in 1 week what a physician in Cuba can make in 1 year, that's an economic gradient you cannot overcome. I don't have a solution to that. The one thing I have seen out there that I think makes sense is that if you look at what Denmark did. Denmark said, when we have a physician that comes from another country, we're going to reimburse that government for the cost of training that physician. That's one thing that you can do. And the other bigger thing that's even on the horizon is if you look at the demographic tendencies in the United States, we have an aging population, and unlike the World War II generation, the generations rising up and now approaching, getting older, approaching retirement, have a much greater need for health care. Use of health and health resources is much bigger in younger populations. So as we go through the demographic, bulge in the next 20 years or so, you have more elderly folks and you have an increased demand for health resources. So that great sucking sound of pulling in health providers from around the world is not going to get less, it's going to get more. Now, one of the solutions is training more physicians in the United States, and that's why there's 13 new medical schools being constructed. But I also think that programs like MEPI, that get us engaged and actually put US dollars into training in other countries is really just a brilliant model. And MEPI is just a 5-year starter program. We need more things like that. And I also think that we need, as a population, to influence Congress. As dysfunctional as Congress is right now, it's critically important because one of the things that's happening now is you've got physicians in the Philippines going to nursing school so they can become nurses in the United States because there's jobs where they can't work, they can make far more as a nurse here than they can as a physician in the Philippines, as an example. So I think one of the things is awareness and enhancing understanding, and again, I don't think any of that happens unless more people engage in the struggle. And again, to take your other point, the last question here about, you don't just want to send people over to impose American-style values, American-style health system, but I think you need to get that understanding more. Because again, most of the population in the United States has no idea about any of this stuff. People just aren't engaged, it's not something that we know, and we're very susceptible to the jingoism or what's out there in the ether. People say something, oh, they do this because of that reason. It's like, okay, I don't know about that. And I always say to friends, when I come back from Uganda, people always say, isn't that wonderful that you do that? They don't have a clue what I do. I could be going over to Uganda, rounding up small, cute, furry animals and beating them to death, and they'd still say, isn't that wonderful what you do? The lack of understanding is a real issue. It's a huge issue, and I think the more people get out, the more people do exactly what you just did, writing a book and getting up and talking, enhancing understanding. I think it's critically important. And I've done a lot of talks in Rotary clubs, and I know a lot of people from our group have done that at medical schools. the more we enhance understanding is great. And just let me share one quick story. I know we went way over. I think we started a little bit late, but this is a story that Harris Wofford said. Harris Wofford, I showed you, was the U.S. Senator. He was in Brookings Institution. And he told the story when the first group of Peace Corps volunteers went overseas. He said he, Sarge Shriver, and JFK went back to the Oval Office. And they were sitting there, and Kennedy looked out the window, and he said, imagine if we could send 1 million people a year overseas. By the end of a decade, there'd be 10 million Americans with intimate knowledge of Asia and Latin America and Sub-Saharan Africa. What would that mean for our foreign policy and our relationships with the world? Our lack of understanding about what goes on overseas is one of the big barriers for any of these issues, because anytime it comes up, it's shot down. And you can see just in the studies from Pipe at the University of Maryland that when people are asked how much money goes into foreign aid, exam, is it 20%, 24%? It's less than 1%. And that lack of understanding is a real stumbling block. So you raise a really important question, and unfortunately, I see things not getting better quickly given the demographic bulge and the issues in Sub-Saharan Africa now. I'm sorry. Yes?
Is there any organizations actually taking even one more step back? For example, measles deaths. But we know that 100% of the measles deaths are in vitamin A deficient individuals. That's why it's malpractice in America that if you have a patient with measles in the hospital, they have to have supplemental vitamin A. If we looked at the money, obviously there's the acute emergency, here are the people, but is there any group or organization that's stepping back and saying, wait a minute, rather than to have a perpetual measles immunization forever, where the American drug companies are really happy, let's look at the vitamin A deficiency in the population. How do we modify the diet? What do we do agriculturally to get vitamin A to it so we don't have the deaths from measles, as opposed to coming in from the other side, let's just keep immunizing them forever? Is there any organization that's stepping back and looking at these next level up solutions?
I don't know a specific organization to answer your question. What I do know is that the United Nations has really probably been in the lead in terms of getting funding out and getting coordination of these activities in Sub-Saharan Africa. I know there's a lot of work in vitamin A. In fact, it's one of the questions that we've been asking people, and it's in every clinic, every outpatient clinic in Uganda, is vitamin A is one of the things that they check off on their list. They're supposed to have vitamin A supplementation. So I know if you look at just the way things work with ministries of health, at least from my understanding of it, from my experience in these specific countries, but a WHO makes recommendations, Ministry of Health looks at those and they incorporate them into their guidelines, and it goes out into the countryside. Now, the barrier comes in that there's a lot of great ideas out there, but these governments have no money. They've got so little money. And unfortunately, there is stuff stolen from the top. Uganda's had 2 episodes in the last 5 years of people stealing millions of dollars while we can't get anything from them to do the program that we're doing, which is very frustrating. So I think the knowledge is there. I think the UN and WHO are really the leaders in this. And I can also tell you there's a lot of organizations out there doing wonderful work. I don't know specifically about one group doing vitamin A, but I bet if you were to Google it, you would find it's either PSI or PATH or Pathfinder or JPIGO, the so-called Beltway Bandits that are these big NGOs around the Washington, D.C. area largely, or in K Street or in Arlington, Virginia, that get these enormous contracts to do exactly that. So I can't address it specifically, but that's sort of the realm and the way it works. And you know, it does work. And it works as we go through time. I'm really looking forward to what's going to be happening in the next 15, 20 years in terms of issues like this. And I think one of the big players to come on the scene when Bill Gates entered the fray, a lot of things changed. And over the last 15 years, there's been just an enormous sea change. When I started writing my book, it was one era of global health. Now it's a totally different era. And it's radically changed because of Paul Farmer and Bill Gates and Bono and Jeff Sachs and George W. Bush. A lot of people came in and entered this and put more resources in than we've ever seen before. So the impact of some of these things are going to be a little bit delayed in seeing, but certainly measles deaths have been falling. Vaccination campaigns have been effective, and there's a lot of other initiatives that are being done. I just don't know specifically about vitamin A.
Thank you.
Okay. All right, and I think I've gone way over, and my apologies, but again, thank you for your attention, and look forward to talking more.
We'd like to thank Dr. O'Neill, very grateful here for his talk. He's going to be available for a book signing after. Is that correct? Yes. So right outside, he'll be available for book signing. He's also going to be with us for a few days. Tomorrow at 9:30, there'll be kind of a small group session if anyone is interested in attending that.